Hello everyone and welcome back to our channel. So as you are all aware, we were discussing the diuretic drugs. So in the earlier videos we have discussed the relevant physiology of urine formation, in which we have discussed the various transporters which are meant for reabsorption of several ions into the tubules and the different sites. And also we have covered the classification of various drugs used as diuretics, as well as we have covered the first class, that is the Highceiling diuretics or loop diuretics, as they act on the loop of Henle. These are also known as loop diuretics. So we have covered the three examples in detail, that is the furosemide, bumetanide and torazamide. So in this particular video we shall cover the second class, that is the medium efficacy diuretics. These are thiazides and the related diuretics, or also called as inhibitors of the sodium chloride symport. Okay, so that's the mechanism by which they produce their diuretic action. Okay, so under this there are two subclasses actually, the thiazides and the thiazide-like, in which the different heterocyclic ring has been utilized. Okay, so actually the chlorothiazide, this was the drug which was introduced as a carbonic anhydrase inhibitor. Later on, a lot of agents were introduced by replacing the thiadiazine ring with other heterocyclic rings. Okay, so activity did not change, the mechanism did not change, but other improved agents were introduced to this particular class. Okay, now these agents are only the medium efficacy diuretics, right? The reason why they act mainly at site 3. We have seen the reason why these are medium efficacy diuretics, because already most of the sodium has been reabsorbed at site 1 and site 2, right? That is the proximal convoluted tubule and the thick ascending limb of loop of Henle, which is site 1 and site 2 respectively. So those which are acting at site 3 will be obviously medium efficacy. Okay, and the low efficacy diuretics are the ones which act in the late DT and the CD collecting ducts, right? So we have seen what is the reason behind this. Okay, so this class is also known as medium efficacy diuretics. Now coming to the mechanism of action. So mechanism of action over here, if you can see that it is similar to that of furosemide. Similar in the sense the way by which it reaches the site is similar. Transporter, obviously it is different over here. Even the site is also different. Okay, now but the way by which it gains access to its site, it is same as that of furosemide. Okay, so it gets secreted by utilizing these organic acid secretory transporters in the proximal tubules. Okay, so it is the proximal tubules where they are secreted, and then they will travel along the loop of Henle, and then it will reach the later parts or the cortical diluting segment of loop of Henle and the early distal tubules, where exactly it acts on the transporter called as sodium chloride symport. Okay, so it's present at site 3. Okay, now here again, just like furosemide, thiazides also act from the luminal side, right? So this is the lumen, right, and this is the ECF. So the other end, it is the ECF, right? So from here, from this side, from the luminal side, it will act on the transporter. Now this transporter have also been studied in detail. As you can see, the name sodium chloride symporter, that means it carries the sodium and chloride in the same direction, one sodium and one chloride ion within the cell, and from here sodium is taken up by the sodium potassium ATPase, as we have seen, and chloride, it is taken up by separate chloride channel. So this is how basically the reabsorption of sodium and chloride will take place. So this mechanism of reabsorption of sodium and chloride is inhibited by our drug thiazide by acting on the luminal side of this particular transporter. Now this transporter has also been studied in detail, and this is also a glycoprotein with 12 membrane spanning domains, just like what we have seen under the sodium potassium 2 chloride synthetase. So just like that, even this one is also a 12 membrane spanning domain. Okay, so this transporter, it is specially and selectively expressed on the luminal membrane. This is a luminal membrane, right? That one which faces the lumen. So this transporter basically expressed on the luminal membrane of the loop of Henle and the cortical diluting segment of loop of Henle and the early DT. So this is where exactly the transporter is inhibited. Apart from that, the thiazides and the related agents also have additional mechanism of action, that is by inhibiting the carbonic anhydrase enzyme in the proximal tubule. Okay, but this action is clinically insignificant. The main mechanism of action is this one, inhibition of this transporter sodium chloride synthetase. That's how the sodium reabsorption is inhibited, so that the excretion of your sodium ions will take place in the urine. Okay, then coming to the actions of the thiazides and the related drugs. Okay, now under the Highceiling diuretics, we have seen that the corticomedullary osmotic gradient is affected. Okay, but here it is not. Okay, so these are the drugs which do not affect the corticomedullary osmotic gradient. Now why do you think this happens? Yeah, that's because of the site of action, right? Corticomedullary osmotic gradient, the maintenance is mainly taken care of by the loop of Henle, right? The descending part is permeable only to water, whereas the ascending part is permeable to only the ions. So this arrangement, the countercurrent arrangement and differential reabsorptive capacities of the two limbs of this loop of Henle helps in maintaining the corticomedullary osmotic gradient, right? But since thiazides and related drugs, these do not act on loop of Henle, right? So that's the reason why corticomedullary osmotic gradient is not altered by the thiazide. This also confirms that it does not act on the loop of Henle, but the site of action is somewhere in the cortical diluting segment. Okay. Then, under the action of these thiazides and the related diuretics, now what happens is the sodium reabsorption is inhibited in site 3, right? That is the cortical diluting segment and the early distal tubules. So as sodium reabsorption is inhibited at site 3, okay, so more of it will be presented to the site 4, right? Okay, so as a result of this, more of sodium is exchanged with potassium. Remember the transporters in the site 4, sodium and potassium, these are exchanged, right? Sodium is reabsorbed, potassium is secreted into the tubules, right? Now since the transporters in site 3 are inhibited, whatever sodium is not getting reabsorbed at this side, it will be presented to site 4. So more and more of sodium will be exchanged with the K plus ions, right? Potassium ions. So what will happen? The urinary excretion of potassium ions will be increased. Naturally, more of it will get exchanged with the potassium, so that more and more potassium will be secreted into the tubules. Okay, so natriuretic response is produced, but at the same time it is causing more and more excretion of the potassium ions also from the body. So this could be the reason why it is precipitating the complication, that is hypokalaemia, right? So this is the complication which may be produced by the thiazide-like diuretics as well. Okay, now the maximum diuretic action of these thiazides and related diuretics, these fall under a narrow range. Okay, now in case of Highceiling diuretics, we have seen that as the dose increases, the diuretic action is also increased, and these are the maximum efficacy diuretics, the highceiling diuretics. But in case of thiazides, this action lies in between a narrow range of the concentration. Okay, but the efficacy, yes, it is moderate level of efficacy. Okay, you cannot call that thiazides, they produce maximum efficacy of the diuretics. The reason why is almost 90% of the glomerular filtrate has already been reabsorbed, right? So only a little amount is presented up to the site 3, right? So these drugs are supposed to act at site 3. So before the filtrate reaches site 3, almost 90% of it has already reabsorbed, right? So that is the reason why these fall under the moderate efficacious diuretics or medium efficacy diuretics. Okay. Now with the use of these agents, acid-base balance of the body is not altered. Okay, though it inhibits the reabsorption of sodium, okay, though it causes increase in the excretion of the potassium simultaneously, but still acid-base imbalance is not produced by these particular agent. Now, one significant action which is produced on the kidneys is the reduction of the GFR. Now, in case of high-ceiling diuretics, we have seen that high-ceiling diuretics do not alter the GFR, right? That's because the compensatory mechanism, hemodynamic changes are produced, but GFR is not reduced, because compensatory mechanisms will come into picture and they will prevent the GFR from getting reduced. But this complication exists with only the thiazide and the related drugs. That's because it produces the reduction in the blood volume. It reduces the blood volume, as well as intrarenal hemodynamic changes are produced in such a way that the glomerular filtration rate is reduced. And this is the reason why thiazides are not effective in those patients who are having low GFR. That is in case of renal failure. The thiazides are ineffective. Now again, a point of contrast with that of high-ceiling diuretics. We have seen that high-ceiling diuretics are effective even in those patients who are suffering from renal failure, right? But that is not the case with thiazide. Thiazides will worsen the condition if they are given to the patients who are suffering from renal failure. Rather, they are not effective because they reduce the GFR. Okay. Another action produced by the thiazides is the decrease in the renal calcium excretion. Remember the point of difference when we had discussed the actions of the high-ceiling diuretics? High-ceiling diuretics, they increase the excretion of calcium, right? Whereas the thiazides decrease the excretion of the calcium. This point is similar. Both of them increase the magnesium excretion, right? So thiazide also increases the magnesium excretion, and high-ceiling diuretics are also increasing the magnesium excretion. Okay, so please note the points of similarities and the differences in between the high-ceiling and the medium efficacy diuretics. Such kind of questions could be asked. Compare and contrast in between high-ceiling and medium efficacy diuretics, or compare and contrast between furosemide and the thiazides, right? So such questions may be asked. So these points of differences are very, very important. The site is different. The transporter on which they act, that is different. Okay. GFR reduction, this particular point is different. Efficacy in renal failure, this point is differing over here. Decrease in the calcium excretion produced by the thiazides, whereas increase in the renal excretion of calcium is true with the high-ceiling diuretics. Okay, so these points of differences should be noted down. Okay. Then the next action which is produced by the thiazides is decrease in the urate excretion. Now this point is similar to that of high-ceiling diuretics, right? The mechanism is same. That is, it blocks the transporters, right? So same transporter is utilized by the Highceiling as well as Thiazide like diuretics to reach its site of action. Remember, it gets secreted in the proximal tubules. So similarly, Thiazides also utilize the same transporters, and that's how urate excretion will get decreased. Okay, even their syntheses may also be increased. So that's the reason why the urate levels in the body may be increased. So a condition called hyperuricemia may get precipitated. Okay, apart from that, there are certain extrarenal actions as well. Okay, so far we have seen what are the actions produced into the kidneys, right? So coming to the extrarenal actions, so it produces a slowly developing fall in BP. That's very important. Okay, so this is the reason why it is used in hypertension. One of the first line treatment, okay, are the diuretics, Highceiling as well as the Thiazide like diuretics. Apart from that, elevation of blood sugar level is also produced. Now why the blood sugar level is increased? That's because of decrease in the insulin release. Okay, insulin is a hormone which regulates the blood glucose level, right? So if the levels of insulin are low, obviously blood sugar level will be high. Now why insulin secretion is getting decreased is because of the hypokalaemia, which is one of the complications produced by the Highceiling as well as the Thiazide like diuretic. So this is responsible for decrease in the insulin release, which is responsible for increase in the blood glucose level. Then coming to the pharmacokinetics, all of these thiazides and the related drugs are absorbed orally, and this is the only route of administration. Again, a point of difference between the Highceiling diuretics and the Thiazide diuretics. Remember, the Highceiling diuretics, in case of furosemide, the oral palate is very low, right? So parenteral route is preferred. Okay, and Highceiling diuretics can be given by the parenteral route, but these are preferably given by the oral route. Okay, their action starts within 1 hour. That is, the onset of action is 1 hour. But duration of action, it may vary from agent to agent. It may vary from 8 to 48 hours. Some of them act for less number of hours. Some of the drugs may act as long as for the 48 hours. So also these agents are having the variable lipid solubilities as well. Now the ones which are having more lipid solubility, their volume of distributions, this will be larger. Remember, the volume of distribution, that's a parameter which is measuring the distribution of a particular drug. Now since it is highly lipophilic in nature, it can cross the membranes and the plasma concentrations will be low. Okay, that is the reason why volume of distribution will be large. Okay, because the plasma concentration is in the denominator, right? What is the formula for volume of distribution? Vd. Yes, it is the dose administered IV. Why? Because 100% will be into your blood circulation, right? Divided by the plasma concentration. So if the plasma concentration is low, obviously the volume of distribution will be high, right? Okay. So volume of distribution of such drugs which are lipid soluble, it will be larger. Okay. So also lower rates of renal clearance. That's because it will get reabsorbed into the kidney tubules as well because of their high lipid solubility. And that's the reason why these agents are longer acting. Okay. Again, the protein binding is also variable. It may vary from the agent to agent, belonging to the same class. Okay. Then apart from that, the metabolism. Most of the agents undergo little hepatic metabolism, and these are excreted as such in the unchanged form. Okay. Now these may be filtered at the glomerulus, or it may be secreted in the proximal tubule by utilizing the transporters. Okay. Now those agents which are highly lipid soluble, obviously these agents will be reabsorbed into the kidney tubules, and the ones which are reabsorbed, they will act for a longer period of time. Then the elimination T half-life of this hydrochlorothiazide, this is one of the example. It's 3 to 6 hours, but it acts for a longer time, that is 6 to 12 hours. Okay. Then coming to the individual agents, chlorthalidone. Now this particular agent is quite long acting. As you can see, the T half-life, that is the time required to reduce the concentration to half of its original value. That is 40 to 50 hours. So you can imagine for how long the drug acts. So this is mainly used as an antihypertensive agent. Next example is metolazone. Okay, now this particular agent is little bit differing in that it is effective even in case of severe renal failure. Okay, what we have seen in case of thiazides, it is not effective in renal failure, right? In those patients who are suffering from renal failure, because it reduces the GFR. But this agent is differing in that it is even effective in presence of severe renal failure. Okay. Apart from that, it acts in the proximal tubules, so that it can inhibit the reabsorption of the phosphate ions, okay, in the proximal tubules. Metolazone, it is excreted unchanged in the urine, so metabolism does not take place, and use is mainly for edema, and sometimes it may be even used for the hypertension. Mainly it is used for edema. Then next example is Indapamide. Now this particular drug has similar action to that of low doses of furosemide. Okay. Now reduction of the plasma potassium level is considered as far as hypokalaemia is considered. It is similar to that of thiazides. Okay. But severe instances of hypokalaemia and arrhythmias may have been precipitated. Okay, so these are on records. So this particular drug should be used cautiously, okay, because arrhythmia precipitation chances are there. Otherwise, it is used as antihypertensive as well as for the treatment of edema. Next drug is Indapamide. Okay, now this particular drug, it has a little diuretic action. Now why? Because it is highly lipid soluble and it is extensively metabolized, and very small quantity it is present in the urine. Okay, that is the amount which is secreted in the unchanged form. That is very little. Okay, so very little drug is available to act on its side. So this is the reason why it has a weak diuretic action. Okay, but it retains the antihypertensive action, okay, due to the extrarenal action. So this is used only for its antihypertensive actions. Then coming to the uses, of course, thiazides are also utilized for the edema, for the mobilization of the fluid, okay, which is accumulated in case of edema. Okay, but thiazides are preferably used only for maintenance therapy. Usually Highceiling diuretics are preferred. Okay, whereas thiazides, these act best in when the person is suffering from cardiac edema, and these are less effective in case of hepatic or renal edema. Okay, and as we have seen, in presence of renal failure, these are not effective. Also in case of cirrhotics, refractoriness may be precipitated. That is, when you give thiazides to the cirrhotics, edema may still persist. Okay, so that's because of the development of the hyperaldosteronism. Okay, because aldosterone, it promotes the reabsorption of the sodium ions. So refractoriness may be produced. Next use is hypertension. Okay, so thiazides and related diuretics, these are one of the first line drugs for the hypertension. Then next use is diabetes insipidus. Thiazides, they decrease the positive free water clearance, and these are the only drugs effective in nephrogenic diabetes insipidus. So also reduce the urine volume of pituitary origin cases. Okay. Apart from that, it is also utilized for hypercalciuria. Hypercalciuria is increase in the calcium excretion in the urine. So this may precipitate the calcium stones in the kidneys. When there is more amount of calcium excreted in the kidneys, there are chances of calcium stones being formed. Now how thiazides will help in this particular situation? We have seen under the actions that calcium excretion is reduced by thiazides, right? So that is the reason why calcium levels in the urine will be reduced and calcium stones will be suppressed. Okay, so formation of calcium stones may be suppressed. Okay, so this to do with the second class, that is the medium efficacy diuretics. Now coming to the next point, that is the complications of Highceiling and thiazide type diuretic therapy. Okay, so since most of the complications, or you can say the adverse effects produced by both of these classes are similar, most of the side effects. Okay, so that's why these are discussed under a common head. Okay, most of these diuretics, these are quite safe when they are utilized in low doses over short periods. Okay, so long-term uses of high doses of diuretics or brisk diuresis should be avoided. Okay, otherwise it will result in complications. So coming to the first complication, so most common and the most significant problem with both these classes is the hypokalemia. Whereas if you use low doses, this particular problem will not be aggravated. Okay, or brisk diuresis should not be induced, or prolonged therapy should be avoided. Okay, so as far as possible, keep the therapy short, and if at all it needs to be continued, the doses should be kept low. Otherwise, hypokalemia may get precipitated. Okay, so if you use a drug over a long period of time, there are more chances of precipitation of the hypokalemia. That is, depletion of the potassium in the body may be precipitated. Now, why this is happening? Yes, that's because the sites of both these drugs, that is the Highceiling diuretics, it acts at this particular level, right? So it will inhibit this transporter. So by inhibition, what is happening? Potassium excretion is enhanced, right? Then the thiazide diuretics, they act at site 3, right? So this transporter is inhibited. Now here potassium excretion is not enhanced, but in both these cases, what is happening? Sodium reabsorption is prevented. So more of sodium will be presented at the site 4. So more of sodium will be reabsorbed and it will be exchanged with the potassium ion. So that's why the increase in the potassium excretion in the urine will take place, and in turn a condition called hypokalemia may get precipitated. So this is the reason why hypokalemia is produced by both these classes, that is Highceiling as well as thiazide-like diuretics. Now the manifestations or the symptoms which are produced, these include weakness, fatigue, muscle cramps, sometimes cardiac arrhythmias may also be precipitated. Now how you can prevent this condition? So there are 3 measures which you can take to avoid the precipitation of hypokalemia. That is, you can increase the dietary intake of potassium ions, or you can give the supplements of potassium chloride, or concurrent use of potassium sparing diuretics. We'll discuss what these potassium sparing diuretics are. So these mainly prevent the loss of potassium in the urine. So these are combined along with the Highceiling as well as medium efficacy diuretics. So these are the 3 ways by which you can prevent the complication of hypokalemia, which may be precipitated when you use Highceiling diuretics or thiazide-like diuretics. Now, mere monitoring the serum levels of potassium may not be sufficient. That's because potassium is usually an intracellular ion, right? So you cannot monitor the levels of potassium in the body by just monitoring the plasma levels of potassium, right? So still what you can do is maintain the level of potassium ions in between or above 3 to 5 milliequivalents per liter. So that may suffice to prevent the hypokalemia. Okay. Then one more complication which may be precipitated along with this is the alkalosis. Okay, so alkalosis may be precipitated along with hypokalemia. Now why this may happen? Now because when potassium is not available to exchange with sodium due to the hypokalaemia. So potassium reserves will decrease, right? So less of it will be exchanged with sodium. But apart from that, one more transporter is available, right? So sodium is exchanged with hydrogen ions as well. So when potassium is not available, sodium will be exchanged with H plus ion. So more and more H plus ion will be excreted out. So this will result in a condition called alkalosis, right? Because acid is getting lost from the body. So alkalosis may be one of the complications which may get precipitated. Then the next complication is acute saline depletion. Acute saline depletion. What is saline? Okay, saline, 0.9% of NaCl, that is isotonic solution, right? Okay. Now, when diuretic therapy is instituted, it targets the loss of sodium and water from the body, right? So sodium, and along with it the chloride ions are also lost, right? So saline, acute saline, why it is called as a saline? That's because along with sodium and chloride, water is also getting excreted out, right? So as such, the depletion of not only the ions but water is also taking place. So that is the reason why the saline is getting lost, as you can see. Okay, isotonic saline is getting lost from the body. It's not just the ions which are getting excreted, or it is not just the water which is getting excreted, but it's the normal saline, you can say, that it is getting excreted out of the body. Okay, so this may result in dehydration as well as fall in PP. So this condition can be treated by saline infusion, as simple as that. Then the third complication is dilutional hyponatremia. Now what do you mean by hyponatremia? That is decrease in the sodium ions in the blood, right? Now why this condition is precipitated? Dilutional hyponatremia. Okay, that's mainly the complication which occurs in the CHF patients, okay, when vigorous diuretics or diuresis is induced by utilizing the Highceiling diuretics. No doubt this treatment will increase the sodium ions as well as water loss from the body. But as a compensatory mechanism, your kidneys will not keep quiet, right? When more and more sodium and water is getting lost, kidney tends to retain water. But since diuretics are acting over here, the salt retention, it is prevented by the use of diuretics, because more and more sodium will get lost, right? Sodium and chloride will get lost. Water will be retained. So as a result of this retention, compensatory mechanism and retention of more and more water, ECF will get diluted. So though the sodium levels may be normal, but since water is getting retained, the condition called hyponatremia may be produced. And this condition is known as dilutional hyponatremia. Because why this hyponatremia is getting precipitated? That's because of the dilution of the ECF. Okay, so this condition may be precipitated along with the edema. Again, the edema may be persistent because of retention of more and more water. So the patient may feel very thirsty. Okay, so usually the treatment of this particular condition, you should withhold the diuretics. Okay, so you should stop the treatment of the diuretics. Restrict the intake of water. Level of intake of water should be reduced, and glucocorticoids should be prescribed to such individuals to prevent the water overload. Okay, even if the hypokalaemia exists, that should also be treated as how we have discussed under point 1. Next complication is GIT and CNS disturbances. So gastrointestinal disturbances like nausea, vomiting and diarrhea may occur, and CNS side effects such as headache, giddiness, weakness, paresthesia, that is tickling, tingling and pricking sensation, impotence may also occur with these drugs. Next is hearing loss. Okay, Highceiling diuretics, okay, especially these are producing the hearing loss. Okay, especially if these are administered in case of renal insufficiency. This because it increases the salt content in the endolymph of the ear and direct toxic action to the hair cells in the internal ear. So this may be responsible for the ototoxicity. These are here ototoxic. Okay, ototoxicity meaning it is toxic to the ear. So hearing losses may be produced by especially Highceiling diuretics. Then next complication is allergic manifestations. Okay, allergic conditions like rashes, photosensitivity may occur. Yes, especially those who are hypersensitive to sulfonamides. Sometimes blood dyscrasiasis may also be precipitated, but these are rare to occur. Next complication is hyperuricemia. As we have seen under actions, both of these drugs tend to reduce the excretion of the uric acid because they utilize the same transporter, right, by which the uric acid is excreted. So that is the reason why uric acid levels in the blood will increase, and that's how hyperuricemia may be precipitated. Now to tackle this particular situation, allopurinol is utilized. Okay, now hyperuricemia can be treated by uricosuric drugs as well as synthesis inhibitor drug. Uricosuric drug is this one, probenecid and sulfenpyrazone. But probenecid should be avoided in this situation. Why? Because probenecid, it will compete for the same transporter which is utilized by both these classes to reach its site of action, right? So same transporter may get inhibited. So your diuretics will not be able to reach its site of action. So better use allopurinol, which is a synthesis inhibitor, xanthine oxidase inhibitor. Next complication is hyperglycemia and hyperlipidemia. So both of these conditions may get precipitated due to the metabolic changes which are produced. Next complication which is produced, now that's relating to your calcium. Now if you can remember the actions of both these drugs, Thiazides, what they do? They decrease the calcium excretion, right? Whereas Highceiling diuretics, they increase the calcium excretion, right? So what will be the complications? Accordingly, it will produce the complication, right? So it will result in, the Thiazides will result in hypercalcemia, right? Both the complications are different for both the classes. Since Thiazides, they decrease the calcium excretion, obviously it will precipitate the hypercalcemia, that is increase in the calcium levels in the blood. Whereas Highceiling diuretics, they increase the calcium excretion, so obviously they will result in hypocalcemia, that is decrease in the calcium levels. Okay. Next complication, now this one will be common for both, right? Because both of them, it will increase the magnesium excretion in the kidneys, right? So magnesium depletion will be produced by both the classes. So because of this, it is prone, or the patient is prone to the risk of development of ventricular arrhythmias, especially after the myocardial infarction or those who are digitalized. Okay. Potassium sparing diuretics, when they are administered along with these agents, they will minimize the magnesium loss. So you can combine the Highceiling or the Thiazide-like diuretics along with the potassium sparing diuretics. Then a complication related to Thiazides, they may aggravate the renal insufficiency by reducing the GFR, as we have seen under the actions. Then brisk diuretics, when it is induced in the cirrhotics, those patients who are suffering from liver cirrhosis. If you induce brisk diuresis, it may precipitate mental disturbances and hepatic coma. Okay, this is due to the hypokalaemia, alkalosis and increase in the ammonia level. So it is quite dangerous to induce brisk or quick diuresis in the patients who are suffering from cirrhosis. Okay. So also diuretics, these are contraindicated in toxemia of pregnancy, that is preeclampsia, or the hypertension which is associated with the pregnancy. That's because in pregnant ladies, despite of presence of edema, still the blood volume is low. So you should not attempt to give diuretics in pregnant ladies. Otherwise what will happen? Already the blood volume is low. Okay. So what will happen? Diuretics will further decrease the blood volume by reducing the body fluids, right, by causing the excessive loss of body fluids. So this will result in compromise of the placental circulation. So the circulation to the fetus may get affected. So miscarriages or fetal death may occur. Okay. So this is the reason why diuretics are contraindicated during pregnancy. Okay. So you should not go for diuretics in case of hypertension in the pregnancies. So these are the complications. And coming to the interactions of the Highceiling and the thiazide-like diuretics. So all of these thiazides and the Highceiling diuretics, they potentiate the antihypertensive agent, because these also have antihypertensive property. So when other antihypertensive agents, if these are combined with the diuretics, obviously additive antihypertensive action will be produced. So this is an intentional interaction which is employed. So purposefully you produce these or tend to induce these interaction to increase the efficacy, okay, or to reduce the dose of both the drugs. You will require a less of dose of each of these drugs when you give it in the combination. Okay. Then hypokalaemia, which is produced as a complication due to both of these classes. So it has certain complications to be precipitated, right? So in case of digitalis, the toxicity of digitalis will be enhanced because of the hypokalaemia. Okay. Also the risk of development of the tachycardias will be enhanced. Okay. So those agents who already cause the prolongation of QT intervals, if you combine such drugs with diuretics, there are greater chances of precipitation of the arrhythmias. So also sulfonylurea action will be reduced because of the hypokalaemia. Okay, so oral hypoglycemics, it will not show efficacy. Then next interaction is along with the aminoglycosides. So aminoglycosides also are autotoxic in nature, and Highceiling diuretics are also autotoxic in nature, right? Autotoxic as well as nephrotoxic. So it will result in additive toxicity. So they should not be combined as far as possible. Then cotrimoxazole, this is a combination of two antibiotics, sulfamethoxazole and trimethoprim. Okay. So when these are given along with diuretics, there are more chances of precipitation of thrombocytopenia. Okay. That is decrease in the thrombocyte level or the platelet levels. Then NSAIDs, that is indomethacin and other NSAIDs, they decrease the diuretic action of the Highceiling diuretics. Also their antihypertensive action may also be inhibited by the NSAIDs if they are used concurrently. Another interaction is with the probenacids. So as we have discussed that probenacid, it will compete with the same transporter, right? So it will inhibit the transporter required for the secretion of furosemide and the thiazide, so that it will not reach its site of action, right? So it will reduce the concentration of these diuretics in the tubular fluid. Okay. Whereas contrast is also possible. Diuretics will diminish the uricosuric action of the probenacid. So there is a competition between the two for the same transporters. Both may inhibit each other's action. Probenacid, it will prevent the diuretics from reaching its site, and diuretics, by utilizing the same transporter, it may affect the probenacid action as well. Okay. Then the serum lithium levels, these may also rise when diuretic therapy is instituted. So this is because of the increased reabsorption of the lithium as a compensatory mechanism. So these are the interactions. Then a small point, that is the resistance to Highceiling diuretics may be developed. Okay, that is known as refractoriness. Okay, now what is a refractoriness to a particular therapy? When you use that particular therapy for a prolonged period of time, after a long or prolonged treatment with that drug, symptoms may start reappearing. Okay, or the drug may not show effectiveness. Okay, that is, in this case, progressive edema may be seen despite of the use of the diuretic therapy. Okay, so this is more common with the thiazide-like diuretics. Okay, and in certain circumstances with high-ceiling diuretics as well. Now, this refractoriness, this may be produced due to renal insufficiency or nephrotic syndrome or cirrhosis of liver or congestive heart failure. So, this could be some of the reasons where refractoriness may be produced. Even the long-term use of the loop diuretics, it will result in nephron hypertrophy, that is, the size will increase. So, again resistance will be produced. Now, to avoid that, sometimes metolazone or sometimes thiazide like diuretics may be added to the therapy. So, also further increase in the dose may also overcome the situation, or you can give the doses in the fractionated form, that is, the divided doses may be given rather than giving single high dose. Divided doses may be given. Also, bed rest may also help to tackle this particular situation. Okay, so this is to do with the high-ceiling diuretics, the medium efficacy diuretics, and the complications of these both the classes, okay, and the interaction of both the classes. Okay, so this is the reference for my presentation. Thank you for watching.